A virus IgM, and which was positive. So she was treated with supportive measure. So basically, she had hepatitis A, acute hepatitis A at that time. Her symptoms and jaundice resolved within 3 weeks. Few weeks later, jaundice reappeared along with arthralgia. The patient medical history is otherwise unremarkable. She takes no medication. Her ALT, AST, as you can see it in the 700, 600, her alkaline phosphatase and total bilirubin all being elevated. The result of other study, including CBC, INR, creatinine, ANA, anti-smooth muscle, and total IgG level were all within normal range. Her ultrasound liver is otherwise normal. Okay, so which of the following is the most likely diagnosis? And I hear from you guys. One or three? We have one, we have three. Okay. We have four, one. Okay. So what's against autoimmune hepatitis here? Normal ANA and labs. Yes, yes. So labs is not all normal. The liver enzymes are actually elevated, but the ANA and the anti-smooth muscle being negative would push you to think about other alternative diagnoses. And I think at this time, relapsing remitting hepatitis A virus are the most likely cause, given that she already contracted the hepatitis A recently. So the right answer is 4. Okay. So a statement just for you guys. The relapsing remitting variant of hepatitis A infection is characterized by multiple clinical and biochemical relapse with spontaneous improvement within a month to 1 year without intervention. Okay? Okay. So transaminitis, ALT and AST greater than 1,000 is suggestive of all of the following except, that's meaning in all of the following, the AST and the ALT theoretically can reach over 1,000, except which of the following? 2, 5, 2. Oh, wow, a lot of 2s. Okay. Okay. So if you guys, there are 3, there is, okay. So those disease, we call them the 1,000 club transaminitis, and they all actually from 1 to 5, but usually the malignants, which is number 6, rarely can reach thousands of transaminitis. Ischemic injury, they see it in the ICU all the time. The AST and the ALT can reach up to 1,000. So the right answer here would be number 6. Okay. A long stem, but be patient with me. 62-year-old woman evaluated during a follow-up appointment 12 weeks after completed treatment for her genotype 1 hepatitis C. She has a child class A cirrhosis, so well compensated. Small esophageal varices were noted in upper endoscopy 1 year early. Physical examination, vitals normal, BMI of 26. She had bowel erythema, spider angiomat over the chest. She have a firm liver edge 3 centimeter below costal margin, and palpable spleen tip are noted. The examination is otherwise normal. Her hepatitis C virus RNA is undetectable. Okay, so she basically gets cured from the treatment. So the question, which of the following is the most appropriate management for this patient? 1, liver transplant evaluation. 2, measure of the hepatitis C virus RNA in 12 weeks. 3, ultrasound for liver every 6 months. 4, upper endoscopy. 1, 3, we have some people mentioning 1, other mentioning 3, 4, 4, 4. Okay, so the right answer in this, which a lot of people actually get miss, is 3. So she still needs to have an ultrasound surveillance to rule out hepatocellular carcinoma. So she's still at risk of developing hepatocellular carcinoma. So patients with hepatitis C achieve sustained virological response, have reduced risk of hepatocellular carcinoma, regardless of patient with stage 3 or stage 4 fibrosis, and this is the clear and the fibro scan. Someone asked that is C. So we don't expect worsening of the cirrhosis. Every 6 months? Yes, it is every 6 months, yes. Okay. We do transplant only for child 3, child 3, and usually those people are coming presenting late, so they will have a lot of encephalopathy, hypoalbuminemia, ascites, so they are in a decompensated state. Okay, so next question, guys. 62-year-olds known to have liver cirrhosis secondary to NFL. He's been followed regularly in the liver clinic, doing his scheduled surveillance in form of endoscopy for liver ultrasound. He's been in compensated state for 2 years. His home medication include nadolol, furosemide, spironolactone. Now he presented to the emergency department with 1-day history of abdominal pain and fever. Vitals were blood pressure 105/60, heart rate 100, chest rate of 18, temperature of 38.2. Was found to have medium-sized ascites. Diagnostic paracentesis were done, showed a neutrophil count of 450. The culture is still pending. So the question, in addition to admission, how would you manage this patient? 1, arrange for an urgent upper GI scope. 2, do therapeutic paracentesis to remove the whole ascites. 3, start ceftriaxone and albumin. 4, administer ampicillin intraperitoneum. So we have 1, we have 2, we have 3, a lot of threes, a lot of threes. For we do an upper endoscopy. Okay. Okay. So don't forget the question was what to do next. And I think the best answer would be giving the ceftriaxone and the albumin. Okay. For the esophageal varices, yes, someone like him, he should have a periodic upper endoscopy, which he was doing. And during admission, if he have any signs of active GI bleed, he also should have one. But the clinical vignette here is just a suggesting of SPP, and for that, antibiotic and albumin would be the key of the treatment. Okay. Okay. So this is just a brief outlines of treating SPP. This is the clinical presentation, common culprits when it comes to the bacteria, and basically how we diagnose it and what to do after the diagnosis and how we treat it, basically third generation cephalosporin, albumin, and if you suspect a fungal, especially in a sicker patient like ICU patient, you may consider antifungal treatments. Okay, next. Okay, 56-year-old women present to the emergency department with skin duration, fever, abdominal pain. Past medical history include dyslipidemia, obesity, diabetes, and gallstones. In physical examination, she was febrile, tachycardic, and jaundiced. She is tender on palpation in the right upper quadrant. She is alert, oriented with normal mental state. Labs revealed elevated alkaline phosphatase and white blood cell. Right upper quadrant ultrasound showed an intrahepatic biliary dilatation. Before moving to the answers, what do you think the most likely cause here? So, what's the diagnosis basically? Okay, we have coli, Brown's disease. I don't know what's Brown's disease, cholangitis, acute coli. Okay, good. Those are good answers, especially ascending cholangitis. When you have someone with right upper quadrant pain, fever, and jaundice, you always should think about ascending cholangitis, okay? So the right answer here would be ascending cholangitis. The suspicion for it should be always high in someone with such clinical presentation, okay? In acute cholecystitis, you wouldn't expect actually dilatation in the biliary tree, and you wouldn't expect jaundice because there is no obstruction of the biliary tree. Is this clear, guys? Okay, good. Okay. So in a patient with liver cirrhosis, splenomegaly, involuntary movement, muscle rigidity, dysphagia, and psychiatric disturbance, you should look for which sign? Okay, wow, good, good. So this is one of the few reason why to call ophthalmology to do an urgent test for someone because it's so specific for a lot of C's, a lot of C's. Good, good for you guys. So Kaiser Fisher ring. I hope you guys all see it here, and it's very pathognomonic for Wilson's disease. So Wilson can affect the liver, kidneys, cardiac, eyes, as well as neuropsychology, as well as a bone. Okay. You guys want to take a break or shall we just keep going? Okay, let's keep going then. Okay. Let's move this here. Oops. Okay, some of you guys want a break. How about this? Let's take a break. Now, what time is it now? Now 2 and 2 minutes. We will start back at 2:10 sharp. 2:10 sharp. Okay? Okay. I think break after 1 hour, it's reasonable. I would like you guys to stay focused. Only going to be another maybe 45 minutes. So let's take a break and regroup in 6 minutes. Bye. Okay, السلام عليكم مرة ثانية. I hope everyone is back. But let me يعني ask you guys question about a level of complexity in the question. Is it too simple? You'd like me to upgrade it يعني to make it more difficult? Is the rhythm is suitable, too fast, too slow? Because we still have 1 hour today and a couple of hours tomorrow. So we always can adjust if you guys see we are going too fast or too slow, or too easy or too difficult. Okay, so so far so good. When some people mention too fast, so whenever you see me too fast, you always can يعني to slow it down. Too fast, more diff, more diff, more differential or more diff, more different. I don't know what's DIFF mean. Difficult. You guys like more difficult or it is difficult? More difficult. Okay. We'll try to bring some more difficult scenario for sure. That's what you guys like. And in the difficulty, of course, the stem sometimes can be longer, but you can learn a lot of things from it. Okay, so let's start back, guys. We have a 28-year-old female evaluated for decreased exercise tolerance and ice craving for the past several weeks. Medical history notable for Crohn's colitis diagnosed 6 years ago. Her symptoms flared 3 months ago with increased abdominal pain, diarrhea, and she began therapy with azathioprine and infliximab. Her hemoglobin level is 82, ferritin of 2, ESR of 88, C-reactive protein is 90. So both ESR and C-reactive protein elevated. Her retics are 0.3%, LDH normal, haptoglobin is normal. The question is, what is the most likely diagnosis? Anemia of chronic disease, iron deficiency anemia, active bleeding, hemolysis. Okay, so we'll take it one by one. Anemia of chronic disease. Or let's park the anemia of chronic disease because it's the more complex one. What's going against hemolysis? Why we are not saying this is hemolysis? Weeks? Okay, the hemolysis can last for weeks. Actually, some people, they are born with a membrane problem. It can be last forever. Okay, LDH is normal. Okay, the retics are low. That's good. So the hemolysis marker are here not suggesting of hemolysis. The normal haptoglobin, the normal LDH, the retics percentage are low. We kind of expect to be elevated if we have hemolysis. Okay, that's good. How about active bleeding? What's going against active bleeding? This patient have a Crohn's disease, so she is prone to have bleeding. What's going against active bleeding? Good, low retics. So when we have active bleeding, the body will compensate by producing more reticulocyte. That's really, really good. Okay, and we left with what's the key in this stem to differentiate between the iron deficiency anemia and the anemia of chronic disease? Ferritin. Excellent, guys. Excellent, excellent, excellent. So the low ferritin, it's actually very diagnostic and pathognomonic for iron deficiency anemia. You're not going to have a lot of disease will lead to low ferritin level, okay? Okay, so that's the stem, and the reason why I brought it here, because this patient can have actually one of those four. They can have anemia of chronic disease, they can have iron deficiency anemia, they can have active bleeding from Crohn's, or hemolysis from the new medication, okay? Okay, good. So to differentiate between the inflammation anemia and the iron deficiency anemia, it's really the ferritin will be one of the keys, okay? You're not going to do a bone marrow for everyone, so this is not going to be very practical. And the rest, you will see a lot of similarity between the two. Okay, next. 40-year-old female had a bariatric gastric bypass 6 months ago. Now she presented to the clinic with symptomatic anemia. So she had shortness of breath, dizziness. Her initial investigation showed a hemoglobin level of 90 with MCV of 107. So the MCV is elevated with normal white blood cell and platelet counts. Blood smear shown. What's the most likely diagnosis here? Okay, so my question is the following. What do you guys see in the blood film, the blood smear? What do you see in the blood smear? This blood smear. Yes, polylobulated white blood cell, multinucleated. That's good. And this is very characteristics for two key diagnoses, one of which is B12, and the second one is folic acid deficiency. Excellent, excellent. Okay. Again, this patient can have, she's potentially can have any of the causes mentioned here. Iron deficiency anemia, but definitely the MCV would expect it to be low in that case. Active bleeding will expect the hemolysis, sorry, the reticulocyte to be high in the roof. And the hemolysis, we are always looking for hemolysis marker as well as changes in the smear reflecting a hemolysis, like target cell orbiting a cell. Okay. Next, which of the following laboratory testing can be useful to differentiate between hemolysis anemia and anemia from bleeding? It's a direct question. One, haptoglobin. Yes, mashallah alaykum. It's good. It's haptoglobin. The rest doesn't play any major factor, but the haptoglobin, it's definitely one of the hemolysis markers. So can we just try to recall 7 of the hemolysis marker? What are the hemolysis marker? One is the haptoglobin. What other hemolysis marker you guys know about? Retics, okay, and mention whether they're going to go up or down, please. So haptoglobin will go down. Indirect bilirubin will go up. Retics will go up. Good. LDH will go up high. Yes. Fibrinogen depends, not all the hemolysis. So I wouldn't consider it as hemolysis marker. Okay, what else? Lactate, not really. It's not considered as one of the hemolysis marker. So how you gonna know whether the hemolysis is autoimmune or non-autoimmune hemolysis? Coombs test, excellent. It is Coombs test. So you would expect in someone with autoimmune hemolytic anemia to have a positive Coombs test. Excellent, excellent. Okay. General feature of hemolytic disorder, so examination, jaundice, pallor, boozing of the skull, especially if they are actually pediatric, splenomegaly, The hemoglobin can be normal, but can be even severely reduced if there is يعني, significant hemolysis. MCV usually increase, reticulocyte increase, bilirubin will be increased, LDH and will be increased, haptoglobin will be reduced. Okay, 30-year-old female admitted with PE. She has history of 3 miscarriages. Her previous workup by her infertility specialist showed a positive test for lupus anticoagulants. What is the most likely diagnosis? 1. MashaAllah. ممتاز. ممتاز. A lot of ones. That's good. That's good. So this is the clinical criteria, and we have the laboratory criteria for diagnosis of antiphospholipid antibodies. It's a long list, but it's worth to go over it because sometimes the question is not going to be so direct, but it's all going to be depend on the diagnosis criteria. Okay, so you have venous thrombosis, and you have to have one clinical and one laboratory. Okay, so venous thrombosis, whether DVT, PE, unusual site venous thromboembolism, arterial thrombosis, or obstetric complication. Our patient so far, she have 3 spontaneous abortion as well as venous thrombosis. She already have 2, and her previous workup showed lupus anticoagulant. So she have 2 in the clinical and 1 in the laboratory. So she have antiphospholipid antibody. Okay, any question, guys? Okay, okay. So let's go to, I think this is an intermediate difficult question. 69-year-old man treated with chest infection. He's been stable in dose of warfarin for 6 months as he was treated for AFib with INR between 2 to 2.5. However, his most recent INR was 5. Which of the following drug that has recently been started is likely to be responsible for the increase in the INR? Wow, that's good. A lot of 4s. Good. The answer is 1. And I know it's so confusing for you guys about those medication interacting with warfarin. This is one of the key why the warfarin been have reduced in the use after the marketing of the NOAC, the new anticoagulant, which doesn't interact with a lot of drugs. Okay, so those, this is only a list for basically the antibiotic can interact with the warfarin. So can you imagine other category of drugs like the anti-epileptic, the heart medication, the anti-hypertensive medication? The warfarin just have a long list of drug-drug interaction. This is why it's not a favorite drug from that perspective, okay? So those are the antibiotic may push the INR higher to supratherapeutic, which increasing the risk of bleeding. One of which, as you can see, is the clarithromycin, while other like rifampin will actually reduce the INR. Is this clear to everyone? Okay. I have to say it out loud. Please notice that the majority of the antibiotic are actually pushing the INR to be higher, so it's increasing the risk of bleeding. The rifampin is doing the opposite. يعني دكتور أنت تقصد إنه تبي ترفع ال INR. No, his INR already, يعني he was in a stable dose of warfarin for 6 months, A level was within the target between 2 to 2.5, and then he was giving a medication in hospital. And medication increased the INR to 5. 5 can be stem, yeah, to 5. So he was giving a medication, increased the INR in that patient, and the medication is the clarithromycin. Clarithromycin potentiate the effect of warfarin. Yes. And along with other, يعني, a lot of long list of medication. Okay. This is just to give you على قولتهم يعني how complex the drug-drug interaction with the warfarin. I think, to be fair, the examiner should يعني only test a common drug being given for people on warfarin, and the common are, of course, antibiotic or other heart medication, because atrial fibrillation, which is the common reason for the warfarin, are basically a cardiac disease. Okay. Okay, so 20-year-old, healthy, found to have the following CBC result as part of blood donation workup. What is the next step? So you guys can see white blood cell are normal, 9.8, hemoglobin 126, but look at the platelets. You only have 20,000 of platelets. So this is abnormal. So what's the next step? Immediate blood transfusion, immediate dexamethasone, blood smear, just to reassure the patient. We have 1, we have 2, we have 1, we have 3, we have 1, we have 4. Okay, this is actually turned to be a good question. A lot of variety in the answer. Okay, so the right answer, whenever you are approaching someone with thrombocytopenia like this, the best next step is to confirm the thrombocytopenia. And the way you can confirm it is by checking the smear. Okay, so this patient's smear should be checked, because a lot of people, they will have some antibodies leading to the platelet to be clumped together only outside the body. Okay, so they're interacting with the tube itself. But in fact, when you check under the microscope, they will have actually normal platelet count. Is this clear, guys? Someone mentioned less than 40,000 should give platelet. Different society will have different thresholds, but they all agree if the platelet count is less than 10,000, true platelet count less than 10,000, perhaps we should give platelet, because less than 10,000 will increase the risk of intracranial bleed. But they all would agree you have to confirm the presence of thrombocytopenia first, and this would be done by examining the platelet under the microscope, also known as smear blood examination. Is this clear, guys? Okay, maybe we should, you guys like us to spend some more time in the thrombocytopenia, approaching the thrombocytopenia while we have this, or it's a sophisticated topic? Or just focusing in the MCQ, probably it's the way to go with this assembly preparation. MCQ, okay, that's okay. 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 Here a long stem. We'll go over a 35-year-old male presented to the emergency with fever, epistaxis. So we'll take it one by one. We'll try to understand question before examination temperature 38.3, blood pressure of 105/70, pulse rate of 24. Is there sites? Okay, good. Let's see this rod here, huh? So first, this white blood cell shape is abnormal. It's not round. It just doesn't look normal. And then when you focus around the nuclei, you'll see those rods. Okay. So this is, as someone already mentioned, I think, as AML. Hemoglobin 98, so they are anemic. 17,000, white blood cell of 3.6, 20% neutrophil, 3% bind, 35% lymphocyte, 23% monocyte, and 18% atypical cell. This is a very red flags. Okay. PT is 24, PTT is 60, fibrinogen is 93. So what's the most likely diagnosis? Yes, as hematologic malignancy as can get. This is a kind of hematological malignancy. Call the hematologist and say, please, I'd like you stat to be attending this patient because they're gonna need a bone marrow and they're gonna need chemotherapy. We may push the rest for tomorrow. Okay. So 22-year-old college student presents to the college clinic complaining of dry cough, malaise, fatigue. The clinic doctor diagnosed him with atypical pneumonia and started him an antibiotic. So the question is, comparing atypical pneumonia with typical pneumonia, the atypical pneumonia is known to be, one, acute in nature with high-grade fever, lobar infiltrate caused by mycoplasma, pneumonia respond to penicillin? A lot of threes. A lot of threes. Good. Good, good, good. Okay. So this is actually, I think it's a nice picture to differentiate between the two. So atypical, usually they are subacute. It takes 10 to 20 days to present seeking medical attention. Even the fever, usually it's low-grade fever. They usually have non-productive cough. And usually they don't have lobar pneumonia. You can see here the whole segment of the lung has been affected, while in the atypical, usually both lungs were infected, and it kind of not focusing in one lobe. It's actually usually in all over the lung. The organism is basically Mycoplasma pneumoniae. That's the common organism, okay? Also Legionella, viruses will be one of the causes, okay? Okay, so second question. 51-year-old businessman complaining of dyspnea on exertion. He's recently returned from business trip from USA. He has distant heart sound on auscultation of the chest. Chest radiograph revealed that there is a thin rim of calcification surrounding the cardiac outline. Which of the following condition is the most likely responsible for this finding? Uremia, elevation in the urea, tuberculosis, group B, Coxsackie virus, sarcoidosis. Exclamation mark 4, 2, okay. So the key here, and I underline below it, is the rim of calcification, which can happen with tuberculosis, okay? Yes, sarcoidosis can have some calcification, but this present acutely, which favoring an infection process, okay? And you can see here, the rim, this is not in the lung. This is actually an example of calcification, rim of calcification in the pericardium, okay? You can see it's like a crescent shape here. Okay. 28-year-old man, and before moving to this, guys, you have to know tuberculosis by heart. Tons of questions going to be asked about tuberculosis or tuberculosis treatment in the usmle. Still, Saudi Arabia is still an endemic from tuberculosis, and this is one of the reasons why they like to ask questions about tuberculosis. Okay, okay. 28-year-old man has tuberculosis with mediastinum lymph node diagnosed 2 weeks ago and started on rifampicin, isoniazid, pyrazinamide, and was admitted because increased dyspnea and stridor. Okay, so chest X-ray showed compression of both main bronchi by cranial lymph node enlargement. The question: what is the next step in management? Okay, I see 3. They said in the outlet 3. Question mark 5. Strong 5. Okay, so sometimes when we start anti-tuberculosis medication, there's gonna be an inflammation in the lymph nodes, and the inflammation can lead to such complication. That's stridor. That's meaning their airway is getting compromised. Yes, you should consider doing a CT. Yes, you should consider placing a stent or considering trach if needed. But the next step, the moment you see this patient, steroid should be given to ease the inflammation in the lymph node. So the key in this question wasn't what should be done. It's actually what is the next step. That's meaning when you see this patient, the next step should be giving the steroid, and then of course involving whether thoracic surgery or respirology to consider the trach. Is this clear, guys? Okay, so let's go over at least a couple of questions and then we can call it the day. Okay. Okay. 28-year-old treated for TB with rifampicin, isoniazid, pyrazinamide, ethambutol. So they started with 4, which is ideal, for 4 weeks. Pre-treatment liver function test was normal, but his most recent one showed bilirubin elevated as 98, AST, ALT both elevated, alkaline phosphatase elevated. Which of the following the most appropriate next step? Stop all, stop ethambutol, stop isoniazid, stop rifampicin, stop pyrazinamide. Three, okay. 3, a lot of 3s, a lot of C's. Okay. You guys are right when it comes to the isoniazid is among the one famously known to cause liver injuries, okay? But actually, they all potentially can lead to that. So what we do, because we don't want to stop only one and then follow the liver enzymes, we stop them all and then we replace them immediately with 2 alternative anti-tuberculosis medication, okay? It's a kind of, you don't know which one led to the liver enzymes. Yes, the isoniazid is the one famously known for it, but you stop them and then you replace them with an alternative tuberculosis medication. Is this clear, guys? Yes, the answer is stop them all and replace them immediately with alternative. We don't want the TB to develop resistance. So it's a kind of 2 parts. Part number 1, we stop them all because we don't know which one among them led to the hepatitis. We replace them immediately with at least 2 alternative TB medication because we don't want the TB to develop resistance. Okay? Okay, let's take the next question and then we can call it the day. Okay. Oh, this is a good question, actually. This is a good question. A healthy 40-year-old male presents for tuberculosis screening. He was asymptomatic with a normal chest X-ray. His last PPD 5 years ago was negative. Today, his PPD is positive. What is the treatment? So, isoniazid for 6 months. Isoniazid, rifampin, ethambutol, pyrazinamide, they didn't put any duration. Reassuring, rifampicin and isoniazid for 3 months. 1, 2, okay. Any other option? 4, okay, we see 4. Strongly 1. Someone asked what's PPD mean? PPD is the skin test for TB. It's purified protein derivative, or also known as the Mantoux test. And it's been used for diagnosis of latent TB. Okay. The reason why I'm saying this is a good question is the following. Okay, so I wouldn't, this is, the diagnosis here is latent TB. Okay, so you can reassure him that he doesn't have an active TB because his chest X-ray is clear, but this is the latent TB. So I wouldn't totally reassure him. Okay, this is one. The second about the therapeutic option, and I will go through the journey I went through before reaching the answer. Okay. Okay. So this is from the Canadian guidelines, and this is just a summary recommended for region for latent TB. Okay. So isoniazid for 9 months is the ideal. It's the level of evidence is 1. This is the recommended one. Okay. That's been said, isoniazid as well as rifampin for 3 months is still a reasonable option. Are you guys following? Hopefully you guys following so far. Okay. So pay attention that they mention here this as a choice. Okay. Rifampicin and isoniazid for 3 months. Okay. And then we're still in the Canadian guidelines, 6 months of daily INH is acceptable alternative. So they still think as an alternative. But then I went to the Saudi guidelines, okay, which I think we should follow because the exam being written by Saudi people, okay? So the recommended regimen for latent TB, 1 is isoniazid for 9 months. This is 1. 2, isoniazid for 6 months. 2. 3, rifampin for 4 months. Okay. So in this guidelines, they haven't actually mentioned mentioned about the combination therapy. What they actually explicitly mention is we shouldn't combine the rifampin and the pyrazinamide is not a preferred. And I will tell you guys, a lot of these questions, sometimes people are not recalling the question right, okay? So maybe in the real deal, in the real exam, this 4 wasn't an option. The option was rifampicin and pyrazinamide for 3 months, which definitely gonna be wrong because it's against the recommendation. Is this clear, guys? Okay. Okay, so let's call it the day. I think that was a good question to end up our MCQ. We will continue tomorrow. I'm happy to stop here and hear if anyone have any question or they would like to go over a certain question. I will be happy to do that.
يا شباب يا بنات, is there any question for Dr. Khalid? If you have any questions, please write it in the chat or just raise your hand. No problem. They're asking if they can get the slides, doctor. So
of course. Shall I? Maybe you can send me your email. I will be happy to share it with you, and then you can distribute it among them. Or can we?
You can upload it here
if
you want.
So tomorrow we'll upload it. Remind me tomorrow. We'll upload it after finishing all the questions.
Sure, بإذن الله.
Okay. Any other question, guys?
Looks like there are no questions.
Then tomorrow is another day. Bring your question if you like. I don't know what's happening here. Okay. And then thank you so much, Dr. Omar, for putting all of this together.
Thank you very much. Thank you. يعطيك العافية دكتور. شكرا جزيلا. يعطيكم العافية شباب وبنات, وبكرة بإذن الله نلتقي. شكرا للجميع. شكرا.